Have the studies in OHT changed my treatment protocol by Dr. MEENA Menon. Dr. MEENA is the head of glaucoma services, Shankara Nethralaya.
Shankaraya Hospital.
Sorry, Shankara Eye Hospital, Bangalore.
Both are. Sorry. So, good morning. So thank you, Smita, for giving us this opportunity to share our whatever we have learned over the years. So the topic for today is, have the studies on OHT changed my treatment protocol? Now, as you all know, IOP is the only modifiable risk factor which we can treat. So patients with elevated IOP and no signs of POAG after standard clinical tests, they are referred to as ocular hypertension. Now, when we get a patient with ocular hypertension, there are many questions which are raised. How often should they be followed up or examined? What are the diagnostic tests which we should perform? Can we identify these patients who are at high risk or low risk for developing open angle glaucoma later? And how many of these patients will develop visual limitations due to primary open angle glaucoma? And finally, which are the ocular hypertensives which are safe in these patients? So, the ocular hypertension treatment study is a landmark study wherein they did a randomized trial determined topical ocular hypertensive medication delays or prevents the onset of primary open angle glaucoma. Let's just go through the study in brief. So OHTS phase 1, which started in 94, which continued till 2002, they recruited 1636 patients, wherein 24 to 32 millimeter of mercury patients were kept under observation, and the people who had 21 to 32, they were randomized into topical anti-glaucoma medication. Now, the goal in the medication group was to reduce the IOP at least by 20% or more, and to reach an IOP of 24 millimeter mercury or less. Now, there are certain demographic and clinical predictors which was shown in this study, some of them being family history of glaucoma, the usage of various systemic medications, then of course the systemic diseases as well. Now, these is the baseline age and the putative ocular predictors by POAG status, especially age, intraocular pressure, corneal thickness, pattern standard deviation in the Humphrey field analysis, horizontal and vertical cup disc ratio. Now, just go through the results of this study, phase 1. The cumulative frequency of developing POAG was 4.4% in the medication and 9.5% in the observation group. And definitely there was a protective effect of treatment which was statistically significant. And they found that there were no risks involved in using the AGM. And definitely it is necessary to monitor both functional and structural parameters. The another important factor is the baseline age, vertical and horizontal cup disc ratio, and PST and IOP are good predictors, whereas central corneal thickness was found to be a powerful predictor for the development of POAG. So it was found that early treatment definitely decreased the incidence of POAG. Now, next was the phase 2, which was from 2002 to 2009, where they randomized these group again into after the phase 1, they randomized into medication, which is continued in the medication group, and the medication was started in the observation group. So these were termed as delayed treatment group. Now, what was the result of phase 2? They found that the cumulative proportion of the participants who developed POAG after 13 years of follow-up was 0.22 in the original observation and 0.16 in the original medication group. And the median time was 6 years to develop POAG. Definitely the percentage protective effect was similar in all three groups, but the absolute reduction in the incidence was small in the low risk and substantial in the high risk group. So with the median post primary open angle glaucoma follow-up of 3.5 years, the PST slopes of participants in the observation group were slightly worse in the treatment group. Now, do cataract surgery help? They found that the cataract surgery produced a lowering of IOP for almost 1 year after the surgery in the medication group and decreased the medication burden for a prolonged period. Now, there came the OHTS phase 3, which is of 2015 to 20, wherein they found that cumulative 20-year incidence of POAG was 45%, with 25% of patients developing visual field loss in one or both the eyes. So this is an important factor, the number needed to treat, or otherwise called as NNT. It is 16 ocular hypertensives to prevent one case of conversion to glaucoma when we use a 20% IOP reduction. What are the other relevant studies of ocular hypertension? European Glaucoma Prevention Study. The difference is that they used only one anti-glaucoma medication, that is dorzolamide, in their study. So they validated the OHTS findings, and the NNT in this study was 143 patients. So EGPS failed to detect a statistically significant difference between the medical therapy and placebo. They had a group of placebo as well. So in reducing the incidence of POG, because placebo also significantly and consistently lowered the intraocular pressure. The other relevant studies, the LIGHT trial, wherein they compared the selective laser trabeculoplasty and found that it is a safe treatment, providing better long-term disease control after the initial than the control group, which had an initial drop therapy. This is just to go through some cases. This is a 63-year-old with family history, mother being glaucomatous. IOP was 30 and 26 with slightly thicker corneas with open angles, and fundus was 0.4 CDR. All tests were normal. So when we get this kind of a case, stratify into the risk group as an OHTS more than 26 IOP at 5 years. If the CCT is less than 555, the risk is 36, and if the CCT is thick, it is around 13%. And look at the CDR. If it is more than 3, with thin CCT, it's around 24%, and with thick CCT, it becomes 16. So this patient, other factor which we include when we treat is the follow-up strategies, how psychologically the patient, how anxious the patient. So this patient was very anxious, and he said that I can't wait like this every time the pressures are slightly high. So we were a little bit, after discussing the patient, started the patient on timolol. Now in such situation, there is a role of diurnal variation of risk calculators. So diurnal variation, this is a good study of kind of a meta-analysis about the diurnal variation. There are a lot of measurement challenges. Are we able to do a 24-hour IOP monitoring? Are we able to do a continuous IOP monitoring? And really, does this have a relevance in treatment? So there are a lot of questions asked, and it's like a full debatable topic about diurnal variation. So it's to the discretion of the physician to decide. Risk calculator tools, there are various risk calculator tools, but one thing we should understand, these predictors can be used as an aid, but not to replace the clinical judgment. This is a case too, wherein again HFA and the OCT turned out to be normal with just 24 millimeter of mercury. So how do we follow up this patient? What we should understand, this patient didn't have any much of a risk factors, so they come under low to moderate risk, so we can follow up in 12 months. If they have high risk factors, as we discussed earlier, we can follow up more closely, and if they are on treatment, definitely we have to observe and understand whether we are reaching the target IOP. To summarize, definitely early medical treatment reduces the 5-year incidence. 5-factor model can be used in your clinical practice. Absolute benefit is greatest in high risk. If not treatment, the patient should be willing to come back to you for a regular follow-up, and the diagnostic tests have to be performed. Almost all the AGMs, as you all know, most of them are safe and well tolerated. Definitely we need to do structural and functional parameters. So the decision is based on the patient's risk as well as their systemic, psychological and social health, and it has to be always discussed with their family members as well. Thank you.